Hello, and thank you so much for joining us today for the webinar Cortical Struts and Computer-Aided Bone Augmentation. It is a great pleasure to introduce to you Dr. Jan Kielhorn. Dr. Kielhorn studied dentistry at Ruperta Karla Universität in Heidelberg, Germany. He is a specialist in oral implantology and periodontology. Between 1998 and 2005, he was a dental assistant at the Implant Educational Center in Oppenheim, Germany. Dr. Kielhorn is a guest professor at the University Ludhiana, Punjab, India. His specializations are 3D diagnosis, navigation, oral implantology, augmentation. Dr. Kielhorn is also the author of several scientific articles. We would like to thank Dr. Kielhorn for being with us today and botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Kielhorn at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Jan Kielhorn.
Okay, so welcome to the webinar about the evolution in bone augmentation. I would like to present a new therapy regarding lateral bone augmentation and the use of a virtual design for bone augmentation. So what is success in implantology? When we look at success in implantology, we can learn a lot from top athletes. What top athletes do is that they are able to visualize. So they start the race, with the end in mind, so they can visualize the final result. For that, you must be able to imagine, of course, the final result, and you have to have something like a communication platform to be able to communicate within a team. Well, in the car manufacturing, also what we see is that you will have a virtual design and a control before fabrication. So we will be using a virtual design and virtual software to try things out before they actually fabricate it. That is something that can also be taken to implantology and surgery. So also, if you would like to just go and design your own home, also you will do this using a CAD/CAM or a CAD software design. So if we look at the virtual diagnostics, we will do this by the means of using a virtual model like a plaster model, which is scanned, or an impression tray made from plastic and allogenic, which will be scanned without even producing a model. Also, we use cone beam data to produce the best diagnosis we have as a 3D diagnosis to be able to plan and communicate a case clearly within the network of all doctors. So implantology, to my eyes, is a prosthetical therapy only, which has a surgical component. It's a form of retention like other forms of retention, but if you're not restoring the function of the jaw, also a good placed implant will not be of no function. We have a lot of osseointegrated implants that are taken out and explanted because of malpositioning or of no function. That is not a matter of osseointegration. That's why we like to plan crown down. So we often start with a prosthetical visualization first. Therefore, we will use software that is used for orthodontics in order to have virtual models that can be put into an articulator that can be analyzed according to gaps, about to tooth size, according to aesthetic setups for orthodontic treatment. And because this is HTML files you get out of this, you would be able to directly order an orthodontic template like, for example, Invisalign, out of the software directly for a pre-orthodontic treatment before implant placement. What we do then, of course, is we check occlusion, because we want to avoid a bruxism. We want to have a canine guidance, because we know that overload in the sense of bruxism might lead to bone resorption, to chipping or screw loosening and fractures. So we like to know that also before. So within one scan, we can check all of these figures in a simple virtual simulation. Also, these CAD/CAM pictures, which are called virtual wax-up, are quite common to the eyes of a technician. Most often, they are not seen by the dentist. So the dentist tries in the definite product, and then he communicates the changes to the technician. Well, he could, if this would be shared via the network to the technician and to the dentist could, before fabrication, have full control and communicate all his changes before the actual thing is fabricated. So also here, the virtual design gives us a great advantage within the network for the communication among the doctors. Also, if we have, for example, a bar construction, and we would like to know if this fits under the wax-up, so we will not have the problem that the final work will look differently like the wax-up we tried in, and the technician will tell us he didn't have enough space for that. So to know that before that this will not occur, we make a virtual design, and then we will just match this with the wax-up, and you will see that this bar construction will not fit under the wax-up. So you might have to enlarge that to the tongue side, which might result in less space for the tongue. So you probably would like to change the kind of construction to locator, telescopes, or else. But you will see the problems like a weather forecast before they actually occur. And so by only pressing a delete button, you could react to that without wasting time or material. Well, coming then to the surgical visualization, we know, of course, that we have effects of positioning of an implant. Also, vertical position of the implant will tell us that if it's a thinner implant that is placed deeper into a bone, to get to the same emergence profile like a bigger implant placed at a higher level, we might need different amounts of soft tissue. So the vertical position of an implant and the size of an implant will also determine the kind of aesthetics you will get. We also know, of course, that distances between natural teeth and implants and between two implants have been well documented in the literature, according to papilla height by Tano Choquet, and according to the distance by Tano, Hessler, Buser, Hahn, also by a lot of other literature. We see that the vertical position of the implant, just changed by 1 millimeter, will have a great effect on the position of the abutment and on the size of abutment and the type of abutment we might like to use. So you see, just 1 millimeter vertically will play a large role. Also, we could do share this kind of picture where you do the virtual operation already within the network with our doctors, with the general practitioner, or with a technician, or with any other dentist, and then we can discuss if the position of this implant is important or not. So we can say we can leave that position because we have to do severe augmentation here and take an optional position, but we can discuss this case in real-time communication with the other doctors working in the network. Of course, we have also the problem that we go to bone augmentation. We see that bone augmentation in implantology is the most difficult and most important factor, of course, for success in implantology. But most often it is the least planned part. It's done by improvisation or by experience. And so you have to go all through the mistakes yourself in order to have this high learning curve. Sometimes it's based on poor diagnostics, just using an OPG, which gives you only two-dimensional view. It is often chosen by a favorite method, so people like splitting or they like bone blocks, but they not chose it by indication. It is mostly not standardized and based on very sensitive methods, which, as I said, have a high learning curve. So we try to make this foreseeable, to use a DVT, a cone beam, to create a three-dimensional data which we can use. So we have here a virtual wax-up and the actual patient, and now we can plan the type of augmentation, the type of implant, where to take the bone from, if we need a donor region or not, and if it would be a one-stage or two-stage augmentation. So what is the concept? Of course, the concept could be that you use, for example, a bone splitting, which will give you width but not height. And for splitting, I would like to have at least 3 millimeters of bone width. So here I can exactly see if I have the sufficient dimension for the splitting. I can see what width I would like to create if I can create that. I know how deep my vertical cut would be, and so probably using a piezosurgery, I can really go on the spot, on the depth I calculated. But of course, with the splitting, I will not get vertical height. Also, of course, we can use a ring technique, which is a navigated bone ring technique. So we are able to, we are able to use a ring, and therefore a ring is a simultaneous augmentation of bone with the implant first inaugurated by Bernd Giesenhagen. And we like also to simulate this virtually, because it may be not for every doctor very easy to orientate himself where to take the ring from, how much bone he can get, and how much bone does he really need. So we always try to have a virtual visualization of this. And then we will see where can we place the implant. We will know exactly the dimension of the bone ring. We know the donor side, if it's autogenous bone. Of course, it will be a one-stage procedure. We will have a vertical and horizontal gain at the same moment. It's a standardized protocol. And of course, we could also use allografts. So I would like to show you now a little movie demonstrating on a stereographic model how this navigated bone ring technique, or a bone and implant as we call it, is performed. The advantage is that you can use a drilling template, for example made by Materialize, to place the implants, and to take out the rings. So we have both options at the same time. If you see in the movie, you can take out the rings if it's autogenous bone from the chin area, from the linea obliqua externa or else. You can, with the 3D data, check where's the best spot to take out the bone ring. And you could also, of course, take allograft ring, which you can get from the botiss, which is an allograft ring already prepared in the size you would need, and use that also for augmentation. The advantage of the system you see is that you will have a pin guiding you. So you have first a pilot drill, of course, and then there will be a pin on the trephine burr, which has an internal cooling, which I find very important, which will lead the trephine burr. Because the trephine burr is very difficult to control on a thin bone ridge. So this pin will guide you to prepare the bed for the ring or to take out the ring. Also, it will avoid perforation on the inner cortical plate when you take it out, the chin area. But of course, this pin has to be adjustable, because the ridge never is very straight and it's not plane. So therefore, we can adjust the length of the pin of the trephine burr in order that it will always reach the pilot drill you performed, so it will lead your trephine burr very safely. So we tried to make of this very nice technique inaugurated by Giesenhagen a technique that can also be used with all the doctors in a very controlled way. Also, the benefit of this system is that the rings will be held in place for the final drill by the template, so you don't have to hold the drill with a forceps or with your fingers or some kind of instrument. When the movie is finished, of course, this movie is also on YouTube under Bone and Implant. You find it on YouTube whenever you would like to display this later on. And after this movie has finished, we will show you the clinical case, of course, step by step of this procedure. So in any kind, you would have missed something about this therapy. Okay, so that is, now we just move on. This is the clinical case now. It's a case where we need horizontal and vertical augmentation and want to do simultaneous implant placement. So first we will place the bone ring and the implant placement. And now as we have the bone ring placed in any kind of software you can use, we can now wonder about the bone and see where can we take this volume of bone out of it. Then we will use a drilling template to perform first the pilot drill to have the perfect position of implant. Then we will use the treff and burr with the exchangeable pin, which will lead us for a very safe preparation of the bed for the ring. Then we will take out the ring. This is now from the chin area, where we will first mark only the ring. Then we will, of course, perform the implant bed preparation fully on this ring, and then we will take out the ring for the augmentation and fix it with an implant system. This is an ankylosed implant because it has to be a passive implant in order not to bust the ring and not to put compression on that bone. You see a nice healing after 3 months. You will see that there's a very nice healing. 3 to 4 months, you get a good osseointegration, good formation of bone. And then we try to use prefabricated screw-retained provisionals for soft tissue shaping and create a very nice soft tissue outcome with a nice pointed pillar, and see that we, using a zircon oxide abutment, we have a nice emergent outcome and enough volume to get a very aesthetic case. So that's a big help to use navigation in this sense, of course. Also, of course, we have the concept if you would like to use a bone block, because sometimes we will need a 3-dimensional bone augmentation, a biological container. Therefore, we would have to know the dimension of the bone block, the donor site where to take it from, the fixation, what kind of screws, what length of screws. Of course, it will be a 2-stage procedure, and the question is, can you use allografts for this? So the software allows you to measure the bone block, to measure the linea obliqua externa. You can really design how deep you have to cut, and you can again use a piezo surgery to cut onto the point to be very safe not to harm any anatomic structures. So this is really superior to any microsaw or to any burr you might use. That's why I like to use the piezo surgery for all kind of cuts in bone. Now, if you look at narrow bone blocks, we have to say that Professor Khoury did a great job in proving that a bone block, the 3-dimensional bone block technique, is working perfectly and gives you good results. What he actually does is that, of course, narrow bone blocks have an autologous bone, shows osteoinductive properties. It has those mesenchymal stem cells, which will differentiate to osteoblasts, but also it will be osteogenetic and osteoconductive. So actually we have 3 properties to bone which may make it superior. The prerequisites, of course, are good vascularization. We will need blood, but without blood we won't have any healing. We need a good contact of the transplant to the recipient site, and of course we will need a good wound closure, which decides, of course, about any augmentation. The findings are that if you use a full cortical or corticospongious block, it's critical because, of course, in the cortical we have a reduced number of cells, and we will have less ingrowth of vessels due to compact structures and less vital bone and more resorption. So we went away from using, and that was what Khoury showed, that we went away from using full blocks in direct contact to the recipient site, but rather make just a cortical strut, a little cortical blade in a distance, and fill that with autologous bone chips, therefore having a biological container which can be fully regenerated because it has blood and cells, and therefore can be regenerated fully without having these high resorption classes we had with full blocks. So the traditional technique would be that you take out a bone block from the linea obliqua externa, here using a piezo surgery. You take out that strut, and you could even use a microsaw piezo surgery to cut it and make two very thin pieces of it, resulting in a thickness of about 0.8 to 1.5 millimeter. Then you can immobilize this with osteotenthesis screws, and you would screw that in a distance, which you would then fill with autogenous bone chips. This will lead to a full regeneration. Here we use some collagen to even improve to even improve the soft tissue structure. So therefore, we will use collagen for that. When we open up the side, you will see that there's a very, very nice bony structure. It's healed in very nicely. The screws are still in place, so there's not a lot of resorption taking place. And when you drill in that bone, you will have a very vital bone that can react to stress, which can remodel, and which can, of course, react to starts of infection. So better than any kind of material which will not be as vital. So if you don't have an opening or flap, it will regenerate to 100%. And a bone block, the aim is, of course, from a bone block to build a biological container. So we want to have a biological container which is a very fixed container, stable container, not a moving container with a solid biological membrane. Because if we have a biological membrane, this membrane will be well adopted by the body, and in cases of complication, we can react to it. If you would have, for example, a non-resorbable membrane, this would be exposed. You would have to take it out. Also, the aim is to fill the container with an osteoinductive, osteogenetic, and osteoconductive material, which enable a high vascularity and achieve a good transplant-recipient contact. And of course, we would like to avoid any micromotion by having a very stable container. So how can we reach that? In order to show the potential, we've been using a collagen tissue matrix from Botiss, which is very thick tissue. And this we would like to just use as a bony plate, to build a container. Of course, this is not stable long enough, but it just shows you the high potential if you create a stable container and you fill that, for example, here with allograft chips. If you have that container and you close it nicely, you will see that when it all heals in, you have a great portion of bone. So we need a stable container, and we need a cortical plate that will be stable longer, for up to 4 months and longer, than any kind of membrane, but it also has to be biological. So that's why we said, okay, we will take a stable biological membrane. Autogenous, yes, but that's taking out a lot of bone. That's another surgical wound. That's splitting the bone. That's a careful material to work off. You might have cracks. The quantity is limited. And in some countries, patients refrain from taking anything out of the body, but you can put something into it. So we said that we created plates from allografts, which is a cortical strut. We call it bone plates of about 0.8 to 1 millimeter thickness. You can also have up to 1.5, but we would like to have 0.8 to 1 millimeter thickness, which has a 5-year shelf life. And now we also have, like if you take out a cortical plate from the linea obliqua externa, a very thin, stable plate, but it's very stable. It doesn't crack as easily. It's also, of course, acellular. It doesn't react to anything. It doesn't cause any immune reactions. It's a material that is well used in orthopedic surgery. So it's a well-used, well-known material, well-proven material. For the bone plates, I will now show you a movie how this functions. And with the movie, you will see that we designed a sort of a paper cutter. We have this prefabricated cortical strut, which is from allograft, and which is sterile. And what you can do now, you have this sort of paper cutter, which you will see, and there you can place in, after you measured the size you want, and easily cut the bone plate to the size you would like to have it. Also, you can then use this cutter, this bone plate cutter, to perforate the holes for it. So the following would be that you first raise, of course, the flap of your choice. If you use a Kazajan technique, a normal flap design, or a Lamellia technique or a tunnel technique. You can use either of these methods, very well known to bone block augmentation. After you measure that, of course, you measure the size you need, then you measure your bone plate, you'll put it into the cutter and just cut it within seconds to the size you want. You don't need to split it, you don't need to hold it into your hands to contour it, which is a lot of time consuming, very sensitive method, which now is not necessary anymore. Of course, what you can do then is that you cut it to your demand, you can drill the holes, and then you can fix it in the distance, like the traditional Khoury technique, and fill it with a material of your choice. Of course, you could still use autogenous bone if you like to use the most natural material. You can use also allograft particles, or you can use other augmentation materials of your choice. We seem to get the best effect if you use also allograft material, because allograft autogenous bone gives you that sort of sticky bone, especially if you mix it with PRF, that is nicely moldable, that gets a nice blood clot, and it's very stable, while a synthetic or other material like bovine structures is not as moldable and will not give you the same outcome. Another technique we developed for that is the feather nut technique. That means if you have a ridge in the lateral posterior, it's often very difficult to screw on a plate at a distance to hold that. To make that even more easy, we provide you with a little 1 millimeter, 0.8 millimeter thick burr, which creates a little groove at the right spot, and then you are able to place the cortical plate into this feather nut technique and make it very stable, and then very easy to fix it with the osteosynthesis screws. That's called the feather nut technique. It's also a very simple technique which you can use easily because all bone blades have the same dimension. So you don't have to contour it a long time to make it fit in that groove. And then of course you can fill that gap again with allograft material and use PRF, a membrane on top of it, or any kind of membrane like Jason membrane would like to use, a long-standing membrane. So it's a 5-year shelf life. So whenever something happens to you during an implant placement, if a wall breaks off, you don't find enough bone, you don't have to talk about the patient of taking something out, which you will not be able to tell him during surgery, but you can just build in bone, and you always have a piece of bone ready waiting for you. That is very comfortable, and it will solve a lot of cases you would not be able to solve that easily. The bone cutter, of course, gives you a nice option to cut it easily in your hand without any difficulty. And then you can really go through that step by step, and you will see that it's a plug-and-play solution which everybody can easily screw on. And so the only remaining thing that is still a lot of skills will be, of course, suture technique, because that will, of course, be very important. But you see, you just can stabilize it, you can fill it with bone chips, you can fill it with allograft chips like we do and get a nice blood clot, and then just close the wound. If you see when it heals in, you will see that you have a very nice healing. You still can see that the screws are totally pressed on bone because the cortical bone is acellular. You won't have a lot of resorption, so it will be a very stable volume. And you see within, you get a very nice bone and a very vital regeneration. So this is a nice outcome where you see this bone heals in nicely. You can use it for all kind of indications. If you use it for the sinus, if you use it for lateral augmentation for the front region, you really see that the blade over the period of time will even melt into the natural bone and sort of partially disappears. So that's a sign for me that this is really adapted by nature and doesn't give you any kind of reactions. We never seen any kind of reactions, but we know that it's a material well used in orthopedic. You can even reconstruct huge cases, like this case done with Siegfried Hölzer, which we operated together, a patient where we did reconstructing of a full, rich left and right, building a solid container out of the plates. So top and left, but of course the gaps within the container are filled with allograft material. And therefore we will see a nice healing, and we will see a nice reconstruction of bone. So you can do whatever with it, because you will have enough quantity. How much you need, you will have it. Okay, that is the new dimension, I find, to have a plug and play solution to be very reproducible for everybody. Okay. Also, you see, in the beginning we had them very thick. This also worked, but we don't want these thick bone plates, so now we reduce them to a size of only 0.8 to 1 millimeter, because we don't want to have this thick cortical plate. But it will lead to a very nice result, even if there's no bone at all. So bone plates in the clinics are very stable biological membranes. You can cut them, you can easily contour them. If they stick out at a certain spot, you can grind in them and close the wound, so you can react to complications which you cannot with non-resorbable materials. You will create a biological container like the Khoury technique, and therefore enable a high vascularity by a good transplant recipient contact. You will avoid any micromotion because it's screw retained, and you're not limited in quantity, and you will have no donor sites. Second thing is we have a reliable clinical proof material from orthopedic surgery. This material in allograft is well proven. In the United States, it's 60% of the market, so it's a well proven material. We just haven't been using it for dental implantology so much in my country. It's always available. The quantity is not limited. You will have a shelf life of 5 years, and you can use it for all kind of indications to reconstruct any wall you will have. So I hope this will be a benefit. Of course, there will be courses available, or you can also see at the Bone and Tissue Days in Copenhagen next year to find courses or lectures on that. You will be willing to visit me in my clinic, of course, to do these courses, and I will be worldwide on tour for it, like now I'm in Saudi Arabia to present this. Me and my team, we would like to say thank you. I would like to show them that all these girls have been chosen by qualification only. And I would like to share my personal email address with you, so in case as you, doctor, have further questions beyond the webinar or among, I'm very happy to communicate with all doctors worldwide, because that is where good new methods come from exchange with doctors, and we cannot do all our mistakes ourselves, so we can learn from each other. Thank you very much, and now we will go to the question and answers section, and I will try to answer the question and answers provided. Okay, so let's first go to the question by Nashish Alam. I hope I pronounced it the right way. Welcome. The total duration for the complete treatment, it's actually a very short treatment because you're not taking out any bone. So just cutting bone and screwing it on would be about a 45 minutes treatment, depending how difficult it will be to suture or to prolong the soft tissue. That is actually the most time consuming. Okay, to put this in place when you have got the right size, it's very fast. We did some courses with students, and we've seen that they were able to put a plate on within 20 minutes. So the main thing is actually the suturing. Thank you very much for your question. Second question would be along to Emil Kalinowski. Yes, I use PRF. PRF is a very good method and predictable, because what I think is that you can improve quality and improve healing not by having any bone morphogenic or whatever, but this fibrin membrane just gives all the body's own to make it heal very fast. So we like to just put it on top of our grafts. So I really like these fibrin membranes, and I think they improve healing and give you more safety for closure of flap and that it stays closed. We have another question here coming up. No, this is not a MSJ block, of course. This is a bone blade, so this is the Khoury technique. It's not a full block. I don't believe in these full blocks at this spot. You don't have to have a membrane on top of the bone plates. If you use allografts, Jan Kielhorn, is that a question for you? Thank you very much for the question. Yes, if you use allografts bone and you put it in PRF fluid, you get a sort of a PGF, you get a sort of a sticky bone, and that you can put into it, and then you got a sort of a fibrin blood clot, and then you don't have to use a membrane. I will still use PRF on top of it just to have the best wound soft tissue closure healing. That's why I use for it. Ilya Golikov, you want to ask what is more preferable in vertical augmentation, allogenic or autogenic? We have to say that if you use autogenous bone for vertical augmentation, of course, you can go a bit higher. That's what we've seen using rings, for example. But the thing is, the bone is limited. It also works with allografts very nicely, but of course not to the same height as autogenic, but with the same results. Asking a question, Jose Emilio Torres. Buenas noches. Which are the most frequent complications they had with the procedure? Well, if you got a good primary stability with that, you will have not a problem as long as you round the edges and you have no sharp things coming through the bone. There are two major main complications. One is if you do bad suture and the flap will open up. This should not happen. If you just have a little perforation of an edge of bone, you have to do the same as you would do if you have bone exposed after extraction. You have to grind on that bone till it gets under the tissue, until you get bleeding points again, and then you can close the soft tissue. So that is good to handle, while if it wouldn't be bone, it would be difficult to handle. Yes, Nazar Babinski, you could close a sinus window with that, and you can even restore to reinforce the membrane to make a new bony heaven within the sinus. You can also use it therefore. Yes, it also works without PRF, of course. You can just use Jan Kielhorn. You could also just, if you use allografts and blood, and it also works nicely, of course. I just like to improve soft tissue because sometimes I have bad soft tissue and we would like to have a very good quality, so I try to do my very best. And if I can add fibrin, this would be a good thing to do. Anonymous user, medical conditions, contraindications and adverse effects. I don't have any contraindications. We have the same contraindications for the material like in orthopedic surgery. So actually there's none as long as you have a normal operable patient with a normal immune system. There's no contraindication in that because there's nothing in there that can cause an immune reaction, or we haven't seen it so far, at least as I know of. Okay, then to Emilian Kalinowski, can I compare two methods, PRF with allograft, xenografts, and autogenous bone? Yes, the PRF gives you the same result in both senses. The PRF for me actually improves wound closure and soft tissue healing. That is what I use PRF for. I don't use PRF to improve bone. So I find it in both effects to be of the same benefit. José Renaud, would you do this procedure on a type 2 diabetic? Well, if you have a type 2 diabetic that can get any kind of augmentation with stable disease and no immune defects and a normal wound healing, of course this will be a normal patient. If he has problems with wound healing, is not stable with disease, or then of course is normal contraindication with implants, you couldn't do that. Nasha Vimsi, you're welcome very much. Vipram Papaka, my friend from Abu Dhabi, my Indian best maxillofacial surgeon in the world. Welcome. In case you have a membrane for covering grafted area, especially in long-standing mandibular posterior segment, which type of membrane would you recommend? If you use a membrane, I would use a membrane that's stable for a long time, so a pericard membrane, for example, like the Jason membrane. I hope this answers your questions. What is your, Douglas Ness, what is your experience with success in bone block surgery in heavy smokers? Well, if I would be American, I would refrain from doing them. But of course, we instruct smokers. It depends, you know. Some smokers have no problems with wound healing. Some smokers have problems with wound healing. So in Germany, we just have to explain them that there's a higher percentage of loss of augmentation, and of wound healing problems if he still smokes or doesn't stop smoking. So he has, of course, a higher chance of loss, but that also encounters for implant placement. Maxim Proko, you're welcome. What kind of I don't understand your question. What kind of allogenic laminates you used? Can you describe this more precisely? William, a corp does the side of the ramus block where you harvest it from fill the bone again? Yes, it fills the bone again. There are very nice studies from Khoury, who filled it with material and collagen, but the thing is it never recovers to full shape, so you have a little bit of loss. But of course, it will regenerate to a certain extent. But now we're using bone blades mainly. We'll not take out so many bone blocks anymore. Oh, allogenic. Okay, what kind of allogenic laminate? This is bone blades from botiss. That's what we use. It's an allograft. And it's from the botiss company, yes. So that's all the questions. I hope you enjoyed the lecture. Of course, you will be very welcome to still answer this question after the webinar. You will be informed how to after I stop this webinar. I'm very happy if I could see you in your countries to show you this very nice method. I would be very happy to welcome you in our clinics in Germany, and despite nice courses for you in 2015. Thank you very much, and greetings from Saudi Arabia to you. Now I have to lecture again. Bye.
Thank you so much, Dr. Kielhorn, for sharing your lecture and your insightful information with us. We'd also like to thank botiss for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Kielhorn may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Kielhorn will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform at www.botissacademy.com and keep an eye out for a growing schedule of online courses. Thank you again to all. Take care and goodbye.